Dr. Keith Sale, VP of Ambulatory, and our ear, nose, and throat specialist here at the health system is here to talk about how to access the clinic and the most common conditions doctors are treating. Plus, Rick Coldry, he is back. He is VP of Pharmacy. He's here to update the supply and demand for monoclonal antibodies and share how supply chain issues continue to impact healthcare from PPE to COVID-19 testing. Dr. Stites also joining us from Studio B. We have him just for a short while this morning. He's going to get back to his patients, so we're glad he is with us. And we're going to tell you about a shot bringing new hope against COVID for immunocompromised people. But first, taking a look at some COVID headlines around the Kansas City community this morning. All students and staff at schools throughout the Kansas City area will need to wear a face mask just a little bit longer. The City Council approving a plan to extend the mask mandate through February 17th. This applies to Kansas City, Hickman Mills, and Center school districts, along with some up in North Kansas City, Park Hill, Platte County, R3, and Liberty school districts. Also, the Lee Summit School Board of Education also voted to extend the mask mandate through February 24th. Olathe schools approving a plan making face masks optional starting February 18th. So instead of looking at COVID quarantine and isolation numbers, the district will look at rates of absences and only requiring masking if those numbers climb above 7% on a school-by-school basis. So please make sure to get your questions sent into us on YouTube, Facebook, and the Medical News Network. You can find links right there on your screen. All right, let's get going. Let's get to our COVID count this morning. Dr. Dana Hawkinson, good morning to you. Any changes from yesterday?
No, we are sitting at 95 active infections. I think we were close to that yesterday. 23 in the ICU, 14 on the ventilator, 89 additional patients in that recovery period, a total of 184. At least we are staying down, again, under that 100 active infections number. We know that across the United States and here locally, the hospitalizations are going down. That is a good thing, but we should also temper that with the fact that we are having discharges, we are having admissions. So even though that number is the same, you have to understand that there are discharges and admissions at the same time. Also, we continue to have deaths. Unfortunately, we did have a death over the last 24 hours as well.
All right, Doc Hawk, stay close. Thanks for that update this morning. Good morning, Dr. Stites. How are you?
Good morning. I'm good, thank you.
Good. Thank you for wearing your red. We appreciate it.
Hey, I want to show you something. I've not stopped cheering for the Chiefs, so I could be go red, go health system, go Chiefs all at the same time. I think that's pretty perfect.
Triple threat. I love that. Good,
Yes,
good for you. Okay, so we've got you just for a little bit of time this morning, so I do want to ask you a few questions, if you don't mind. I know we heard from our CMOs on Wednesday. Just give us an update on where we stand with the impact COVID is having on our health system, and just what can you update us on?
I think a couple things. First, we're still seeing a lot of death, and we're still seeing a lot of hospitalizations. We're still by far at the biggest peak we've had since the entire pandemic. And we would expect that curve isn't going to be like the testing curve. So the testing curve is dropping down pretty much like a straight, it's going down pretty fast, just like what we've seen across other areas of the country. But what we know is that the hospitalizations are stuttering a little bit in terms of their decline, which is what we're seeing. You go down a little bit, you hit a plateau. You go down a little bit, you hit a plateau. The second thing is that we're still seeing a lot of death. And I think that in America and in the United States, the rate of death is almost twice of what it has been in other industrialized nations. And so not exactly sure what that's about. We think it's due to A, not as much vaccination, and B, most definitely not as much booster. So if you're going to be completely, what I'm going to call completely vaccinated, that is, I've gotten my primary series and I had my booster shots, and so I'm really up to date. Are the undervaccinated, those are the people who maybe didn't complete their primary series or haven't had their booster shot in over 6 months, and then there's the unvaccinated. Well, it's really it's a story now of three worlds. The fully, completely vaccinated folks, all up to date, are doing really well, and they're really doing well on admissions, they're doing really well on death and on ICU stay. The undervaccinated are not doing as well as that, and the unvaccinated are doing the worst. So it's kind of like what we would predict. If you follow the rules of infection control and you get vaccinated, you do great. The second thing is that we know this is taking a tremendous emotional toil on everyone. People talk to us sometimes, they say, gosh, you guys just think about masking and vaccination. You need to let us go live our lives. It's just going to be forever. And you know what? I think that is true. I think this coronavirus is going to be endemic in one of its mutations and one of its forms. And we have to learn to live and coexist with it. And I think what the school districts are doing is actually great. What they're saying is, man, if our numbers go up and we can't keep kids in schools, we're going to put our masks on, because you know what? Every time we do, the kids stay in school. Oh, wait, masking works. And then the second thing is, as the numbers come down, and I think they are going to come down, then I think we can begin to relax a little bit more and go out and enjoy life and do the things we want to do that we know bring us all great joy. And we don't, we're not complete killjoys here. I know that maybe Hawkeye and I can come across like that, but we're really not killjoys. We're just trying to go out and make sure you stay safe, because we do know how to do that. We do know how to bend the curve, because we keep doing it whenever we have to. And the reality is that keeps us safe, and that sets us up to enjoy the joy when we can at a safer moment. And as Omicron begins to fade and people are vaccinated, and a lot of people will have had some native immunity from having had Omicron, I think this spring and early summer, hopefully Hawkeye, we're going to see a really good period. The last comment I would make is, give your healthcare workers and all your frontline workers a hug, at least a virtual hug, because I think there is an increasing sense of intolerance around this. We've forgotten that the virus is the enemy and not each other. When you turn a bedside nurse into the enemy, you've got a problem. Because the nursing staff, the respiratory therapy staff, the folks who are up there taking care of all of our COVID patients all the time should never have to bear the brunt of a political argument. We have to remember, and we have to be better than that. The virus is not the enemy. The people out there taking care of you, they are not the enemy. And please never treat them like that. Because that, I don't use super strong language a lot, but I'm going to say that's a character issue, and that's unacceptable.
Well said. Dr. Hawkinson, you had some comments.
Yeah, I think Dr. Stites just brings up such great points. Just want to echo those things. We continue to know and understand that those people that are vaccinated and up to date, have their boosters, continue to do well, have a lower risk of hospitalization. We know that's true. We see that information coming out. I think Dr. Walensky talked about that on Wednesday or Thursday, talking about how much fold or multiplication increase of risk you have if you are not up to date with your vaccination and booster. We know that it's really, we have some good information. A new article just came out in Nature of Immunology or Nature Medicine, talking about it's really that 3 exposures to spike. And so even Dr. Stites said, even if you've been infected, it's really those 2 other doses of vaccine that are really going to give you, number 1, high antibody levels, but also an increase in breadth or wider range of antibodies, even to those variants that you haven't seen yet. So I think it is very important, even if you have been infected in the past and you haven't been vaccinated, to go get that vaccination. If you have been vaccinated, it's important to stay up to date with your boosters, because around the nation it continues to hold true that those people that are vaccinated and boosted, i.e. up to date with their vaccinations, continue to have a lower risk of coming here to the hospital.
Hey, Dr. Stites, can you update us on the BA2 subvariant? How are we making sure that this doesn't turn into another Omicron? What can people do? We're getting some questions about that.
You bet. Hawk and I can tackle this together. Look, there are going to be variants all the time. And the answer is the rules of infection control continue to keep you safe and travel with you wherever you go. So as long as you follow the rules, this new stealth variant, it's no different. There really look like there are 3 different variants so far that have been identified around Omicron. And there are modifications, there's slight changes to Omicron. And there were some concerns that this new stealth variant the BA2 could evade the testing done with PCR, that's the nasal swab. We know that our nasal swabs pick it up. We know that most of them actually do. And honestly, it doesn't act a lot differently in patients. It doesn't avoid vaccination anymore. It's not causing an increased severity of illness. I think the key is that not to get overly excited about it. There's some early stuff that says it may be a little bit more transmissible, are a little bit better able to avoid your host defense for at least the first line, the antibody-mediated things, but it's not clear that it is significantly or substantially different than the Omicron variant. And the reality is that if you just practice good infection control, if you are fully vaccinated, you've had your booster, you're going to be safe. And Hawkeye, I think that's a message people have to remember. Don't get all caught up in the stealth storm. Remember that really It's not that different than Omicron, which is not that different than the original Wuhan strain.
Yeah.
And the reality is what we need to do is just make sure we follow the rules.
Yeah, I think that's right. I don't think we can emphasize those points enough. You know, what we have seen really is maybe a situation or a flux and change in the situation from Alpha to Delta, but we know that Omicron is really being compared to Delta. I don't believe there's much difference from Omicron to the original Wuhan isolate. And I think the stealth originally was called the stealth because, not to get too technical and scientific, but on the PCR tests, we would miss those targets for Omicron. Some of those PCR tests would. Now those PCR tests are not missing and they are hitting them. So when you were missing that, that was an easy way to tell this as Omicron, as you now are being able to detect that target on the PCR test, because a lot of PCR tests have 2 to 3 different targets within that genome. Now you can't really tell it's Omicron, but you still know it is SARS-CoV-2. So I think that's the important thing to remember. And just as you said, Steve, really the clinical spectrum is not to change. And what have we seen since the vaccination age? So when vaccines became available, we have seen that vaccination, when up to date, continues to protect you against hospitalization, severe disease, and death. And I think those large concepts are really what people should understand.
All right, before we get to our conversation with Dr. Sale and Rick Coldry, do we have any reporter questions on the line with us today? All right, we're going to move forward. We'll get to some community questions here in just a moment. But Dr. Seitz, before you have to go, I want to bring you into this question and bring Rick in as well. We've had a lot of questions from reporters and also the public about ongoing efforts to force physicians to write prescriptions for certain medications, like hydroxychloroquine, ivermectin, and then they would require pharmacists to fill those prescriptions. So I want to ask you, Dr. Seitz, just if you could update us on what we know about those efforts. And then Rick, I want to talk to you about what's concerning you regarding that. Dr. Seitz?
Yeah, thank you. This ultimately is a question about just about risk. So when you go to medical school, you go through all these classes in pharmacy and pharmacology and infectious disease in this case or whatever, and then you go through and that's 4 years, and you go through your residency training, that's 3 years, and for me, medicine, and then I was a chief resident, and I did specialty training in pulmonary. So after college, I trained for, oh my God, it felt like another lifetime, but for another 12 years to become really qualified to take care of people with lung disease and infectious disease. And I do a lot of cystic fibrosis. We've talked about that before, and lung transplant and things. And so at the end of the day, when you put all those things together, and then you spent a lifetime reading and having to get recertified, I had to pass my pulmonary boards. You have to do that every 10 years, did them again in November of 2020. And so, as you stand back and you look at that, I've been in medicine since, 1986 when I graduated from medical school, and I went to med school in 1982. So that makes me 62 years old. So there's just this accumulative wisdom that comes about. And I'm willing, because of the training I've had and the training that our med students and physicians and advanced practice providers have, you're willing to take on risk around doing things that may not be an FDA-approved therapy. For example, in cystic fibrosis, back in the 90s, we didn't have any drugs for CF. And there were these small studies that said, hey, look, if you do a certain kind of antibiotic and you inhale it, you can decrease the number of exacerbations and other problems CF patients have with their lungs. And that drug, like gentamicin or tobramycin, was not actually ever approved for CF in particular. And so, but we were using it because there were some small studies in a small patient population that said, we think there's some benefit, we don't have other good choices to use, and we called that an off-label use. And then I had to work with pharmacists to say, including our own, and say, guys, what do you think about this? And we'd look at it together, we'd look at the information together, we'd work at it, and then we'd follow the patients really closely to make sure they were doing okay. But in each of those instances, we used an off-label use of an approved drug, tobramycin, gentamicin, colistin, because there wasn't other good therapy available. There just wasn't another choice, and people were dying. And so we tried to do that. And today, the FDA, finally, they've gone out and they've studied it, and indeed, there is a form of tobramycin made specifically to treat patients with cystic fibrosis who have certain kinds of infections in their airways that they inhale. But for 10 or 15 years, or 20 years, there wasn't. And so we did use an off-label use. But I accepted that risk. of prescribing it to my patients. And my patients knew that I had worked hard, and we talked about it together. The pharmacists knew, and they had to accept the risk of putting it together. And some pharmacies didn't do it. Some docs wouldn't do it. I went to national meetings and went to cystic fibrosis meetings, and we'd sit there and we'd talk about, okay, what's the best therapy? We'd all talk about it with these scientific symposiums. We'd have lots of presenters, and people would talk about their experience and their evidence. That's not what's happening in the discussion when you say to a pharmacist and a physician, you must write or you must fill these prescriptions. Instead, what's happening is the patient who has not studied the issue to the degree that a Rick Coldy or Steve Stites or the people who have practiced in these kind of areas have, you're saying that the patient now has the power to make the decision, and we simply have to go along with that. In my mind, that's what you do when you walk into a drugstore and you buy an over-the-counter drug. Because the FDA has said, look, the cumulative wisdom is these drugs are really safe, they're pretty effective, and we're going to let patients make the choice, not the physicians, not the pharmacists. We're going to put them out on the counter. Anybody can buy them. And that's essentially what legislation like this is doing. It removes the people who have worked with the medications the most and said they're so safe, you can take them, and you patients can go decide how you're going to do it. We'll give you the prescribing insert. We'll tell you what you should do, but at the end of the day, you can do whatever you want because you can buy the medicine over the counter. And so if drugs like ivermectin and hydroxychloroquine are over the counter, then go do that. But I think as long as they are prescription medications, then I think the question is, who holds the risk? Is it the physician and the pharmacist who've studied and been in this field for a very long time? Or is it the patient who holds the risk for the actual prescription and dispensing of those medications? At the end of the day, you can use ivermectin and hydroxychloroquine off-label, just as I did in CF or other drugs for many years. Still do. The question is, who's going to hold the risk for that decision? And can, as a physician who understands this world, has studied it and practiced in it for years, can a patient tell me what to write? And I don't think that's right. I think if the FDA's made a decision that's going to be over the counter, okay. But until that time, I believe that the risk and the knowledge lie with the physician and the pharmacist. And politicizing it, is not the same thing as taking care of patients. It's politicizing it for a different agenda. And I don't believe that's the right agenda when I'm in the room with a patient. Patients should not be able to tell me what to write. It's like my trying to tell the architect what he has to draw, or trying to tell some other business person in a job that I don't know anything about. I don't really understand how to do their work. Rick, I don't agree with that. And I think the thing to do is make sure you put the decision making when there's risk like that, the decision making about whether a drug is safe to prescribe or safe to be filled belong with the provider and the pharmacist, because we've studied for generations trying to make sure we do the right thing for patients.
Thank you, Dr. Stites. I know Dr. Hawkinson has some comments, but Rick, I do want to ask you,
Sure.
just comment on what you've heard Dr. Stites say, kind of help us put this into perspective from a pharmacy standpoint.
You bet. I think, Dr. Stites covered really well. Such a great story about those drugs in the early CF, and I remember that with you, Dr. Stites. So
Yeah, because you were helping me.
yeah. So I think that's all true. The other thing I think about this kind of movement is really difficult is not only have people gone to school and education and so we're informed, and our purpose and role is to heal others and keep people safe. And in particular, the role of the pharmacist is that we keep people safe. And I understand that there may be disagreement about the information around those drugs for COVID-19, but the science really is very clear. Those drugs are not effective, and they can carry significant side effects and risks. And so if there's something in place that forces a physician to write or forces a pharmacist to dispense something that they know for a fact is not going to work and is likely or very possibly going to harm someone, it violates the entire reason why you decided to go into the healthcare profession, and it violates the oath of a pharmacist, and it violates the oath of a physician.
It doesn't. It's not a prescription. I
It's-
mean,
it's- it's
I think
not.
that's why you have that, Dr. So. You can jump in
That's
as
right.
well, because I've never seen you sit so quiet so long. So please, feel
Neither
free to
have
jump
I,
in as
Sal.
well.
What's wrong?
Right? I know.
Just waiting my turn, Dr. Stites. Just
asleep.
waiting my turn.
Dr. Hawkinson
Yeah.
did have a question. Have
Yeah.
some comments, Dr. Stites, after your comments. Go ahead.
Yeah, Steve, I enjoyed that, the anecdote and the story, and I totally agree with you. You know, we know some of those drugs, you specifically brought up ivermectin, we know that can be used in off-label. We know dermatologists use it, but there is literature support that. I would also like to say, you know, although we do try to bring big concepts into the general public so that you understand, there are significant details in medicine that we do take into account. And Steve, you were talking about using that off-labeled medication for those CF patients because they had a bacterial infection. We know that drug you were using was approved for bacterial infections. You were not using that drug for other organisms like fungus or viruses, in which we know there is no activity towards those organisms. That holds true for a lot of different things. It's like, for instance, giving azithromycin for sinus infections when we know that the vast majority, 85% or more of sinus infections are actually viral, and you're going to recover from that in 7 to 10 days. So I think there are large concepts, as we talked about, but there are also those granular details where we know even though you were using that drug off-label, it was for those pathogens that it was approved for. It was for those bacterial pathogens. You weren't using it to treat influenza or rhinovirus. You were using to treat you were using to treat bacterial infections. So I think that is one distinction there as well. And I think that helps people and understand off-label use, that yes, you can use it, but in the way that you were using it, you also knew that there was literature to support that you were using it towards pathogens which were sensitive to that drug.
Well, and the
Keith,
overwhelming, just to say, the overwhelming debate, when you go to these national meetings, there's a huge debate. People say, well, this is the right thing to do, wrong thing to do. Let's look at all these studies. How do you guys do? How do you do? And there's an active discussion. And all CF centers were doing the same thing because we all felt like it worked. So the people who had studied it for their lives were trying to say, okay, this works. And then we all got together. We did a study on one of them, tobramycin for inhalation, TOBI, and it does indeed work. Okay, that's so different. To your point, Hawkeye, that's completely different than what's happening right now. We didn't have individual people running out and just doing it on their own. And I think it's just a completely different thing. And the problem is, at the end of the day, you have effective therapy. If I'd had a vaccine to protect CF patients from bacterial infection in their lungs, you know what? There would have been 100% uptake of that vaccine, and no one would have had to worry about doing off-label use. Second point is that at the end of the day, if you just remove the political rhetoric for just a minute and ask ourselves, who should really write a prescription? Should it be a patient who hasn't studied medicine, or should it people who try to study and help everybody every day? I mean, I gotta run in a second. So I gotta go see patients on the floor who are sick, and we're gonna redo their medications. And you know what? I've studied my lifetime to make sure I do that well. That's just not the same thing. It's like my thinking, I really could have called better plays than Andy Reid in the second half. But the truth is, I wouldn't have been able to do that. I could think I could do that, but I'm not qualified to do that. And so I think at the end, if we can just take down the rhetoric a notch and just ask ourselves, do you really want patients just being able to ask for any chemotherapy they want? Do you really want patients to just be able to say to the doctor, you have to do this? And why would we pick out two drugs like ivermectin and hydroxychloroquine? Why are we picking out those two? If we're going to fight about this, why are we going to pick about those two? And the answer is because, you see, that's politics. And we've said we're not going to flap with the truth and jack with the truth and flap our arms and scream at you. We're just telling you the truth. We work hard for you every day. And darn it, I don't want to see the doctor-patient relationship, the pharmacist who I guarantee is a buffer between me and doing the wrong thing every day, and a great buffer. I just don't want to see us have that usurped.
Dr. Stites, hang tight. I have one more question for you, but I do want to hear from Dr. Sale, just your take on this. When you talk about that patient relationship with the physician, and then you add medication into this. What would that mean from your standpoint?
The bottom line for me is it comes down to patient safety. We, as Dr. Stites mentioned, are willing to take on a certain amount of risk with our patients and their treatments based on our years of training, based on our years of research, based on the time we've spent in meetings listening to other ways of doing things. And so there are some acceptable risks that go along with treating patients who have conditions that aren't responsive to traditional therapies. And so I think there are opportunities out there to do those things, but again, under a carefully studied environment. And when you remove the checks and balances that are in place to help maintain patient safety, you remove the accountability and the responsibility from the physician and the pharmacist to maintain a safe environment for that patient. I think ultimately, to me, that's really what it comes down to. And I think if you allow the patient or an agency to say you have to do this, again, it removes all those barriers we've spent years, decades putting in place to keep our patients safe.
Has anything like that ever been proposed before with other medications? Like somebody would have to do that?
I can't
That
even.
anyone remembers?
Not that I'm aware of.
No.
To
No.
my knowledge.
Okay,
It's-
no.
No, I'm
it's
old.
unprecedented.
What happens is, again, and Rick, comment on this.
Yeah.
When people think that things are so safe and people can make the decision, we go to over-the-counter meds, right? That's Tylenol, Motrin, vitamins.
Right.
That's Prilosec, Pepcid. Next, all those are over-the-counter medications. So if folks want to say, let's have that discussion about hydroxychloroquine and ivermectin. I would not let them be over-the-counter medicines myself because they have way too many side effects. They can do things. It's a little dangerous. But if you want to have that discussion, then the patient can hold the risk. But man, I tell you what, and I doing that in the absence of clear safety evidence and clear evidence of their effectiveness for a disease that's relatively new that people are politicizing just seems like a completely terrible idea to me. But if you want to allow a patient just to get it at any time they want, which is effectively what some of that legislation in different states is doing, then just make it over the counter.
Dr. Stites, Rick, please.
Oh no, I was just going to agree that that's what the purpose of over the counter is. And just as a quick story, and you guys will find this funny, I think. Many years working in the pharmacy at the retail counter, and you know what I got the most questions from patients about?
What?
Over the counter meds. So they're coming and asking for advice, help, making sure they got the right thing. So it's just kind of interesting that we would put something out there that would maybe force these drugs that are not over the counter and carry these risks. And within my experience, over the counter, patients want your help and advice with.
Yeah,
So
that
it's
puts
kind-
it into
It's kind of
perspective.
ironic.
Yeah,
so.
that helps us understand.
Yeah.
Dr. Stites, are you talking? You're on mute.
Yeah, just think of all the stuff you hear about now, all these things that people just make up and they put out there, look at this special weight loss drug, look at this special diet formula that's going to make you feel so strong, and people start taking it, and then they get sick, or they don't take it right, or it doesn't do anything. I mean, this is snake oil, folks, and that's trust the science. We don't have some motivation. We're not making money off of vaccinations. By the way, we lose money off of vaccination because we have to give it for free. We have to. It's just the political rhetoric around there. It just makes your head hurt because it's just so untrue.
Hey, Dr. Stites, we have a reporter question on the line. Kansas City Star, go ahead with your question.
Hi, my name is Kanala. I'm wondering how hospitals are going to deal with Omicron cases coming in, and if there's a timeline for what's expected for hospital capacity. For example, are people still pushing back elective surgeries, things like that?
You bet. So the numbers, a couple things have happened. So first, our numbers are down from 223, 224 to 186, which is still incredibly high. Remember that in February of 2020, we would have had 0 COVID patients. And so somehow we've had to find another 200 beds for people with COVID, which is, the healthcare has changed so much in order to accommodate that and to be able to take care of folks. So we did have to stop elective surgeries. We did have to try and push down some clinic appointments because we had to shift nurses from the ambulatory side over to the inpatient side to support all the patients we had. The good news is that the numbers of our staff who are sick have dropped 60, 70, 80%, and depending on different area. And as a result, we're better able to staff our inpatient units. So we've opened up our ORs. Now we're not all the way back to normal, but we're not at one point we had to decrease them by 50%. And when you looked at that list of patients who were having to not do surgeries on it was tough because there were some really sick folks on there. But fortunately, we were able to do those surgeries now, so that's going a lot better. Our clinics are ramping back up. Keith can talk about that because he's been involved in that process. He's also been helping with our OR things. So I think we're better off. And I think that's true on the CMO calls. We're hearing the same message. Things are better off. We had our CMO session here on open mics with Dr. Stites on Wednesday, and you know, folks across the state are better off. And so I think things are trending in the right direction. And my expectation, if you look at New York and New Jersey or London or South Africa, is they're going to continue to get better. I do think the Omicron numbers are going to drop. I think it's going to take, you know, probably most of February to really get us into early March to really see that. But I think the rate of community transmission is dropping. And my suspicion is that, man, if we can still do that and still try to be as careful as we can, that, you know, we're in for a pretty good late March, April, May, unless there's another variant that arises. And that's the unpredictable part, which is what we are going to have to learn about COVID. We're going to have to learn that SARS-CoV-2 can change pretty rapidly, and we have to be ready to pivot rapidly, because otherwise we'll end up hitting times in our healthcare system when we'll be overwhelmed just like we were. Sure. And what happens then is if we can just learn to pivot quickly, meaning make sure get your vaccinations up to date, wear a mask in your big public settings, do the things to help blunt the effect on the healthcare system so we can continue to take care of everybody. Otherwise, we're going to see the rates from heart attack, stroke, cancer, trauma, and everything continue to rise, which, by the way, they already have. Remember, U.S. life expectancy is down by about 2 years. And why is that? It's the combined impact. First of all, there's COVID, which takes lives. And second of all, there's COVID that crowds out our ability to take care of everyone. And I think that's our biggest fear in healthcare is when we can't take care of people we know we can save. And that, you know, that's why we keep saying, guys, there's risk to you and there's risk to everyone when COVID's a big outbreak, and we know how to avoid that risk. So please help us. So we got to learn to pivot. That's the lesson. We got to learn to pivot rapidly. The good news is that I think the numbers are going to fall, and we should be I'm hoping we're in for a pretty good spring.
Dr. Stites, thank you so much. I know you need to go. Thank you. Have a great weekend. We'll see you Monday.
Go Chiefs.
Yeah. All right. Go red for Women Day. That's what we're focusing on. Guys, we're going to get back to you in a second, but I want to introduce everyone to Alexis. And we've got some fun news to share with you. We mentioned at the top of the update that today is Go Red Day for Women, and which is why we all called each other. I actually did text you yesterday and said, guys, wear your ties. It's very exciting. So, and Dr. Stites did it too. So proud of the boys. Okay, so Alexis Dulcid is also going red today and joins us to explain more. Alexis, so great to see you. Good morning.
Good to meet you and join you like this, Jess. Good to see you again. This is fun. We actually have a super serious topic as well. The reason we're wearing red today is because of heart disease. Heart disease is the #1 killer of women. Today, the American Heart Association wants everyone to wear red to raise awareness for heart disease. So I talked with 2 women here at the University of Kansas Health System. These are professionals who are at the top of their profession. They have dedicated their entire lives to heart health. Nurse practitioner Shirley Verbenek and cardiologist Dr. Shannon Hughes-Thompson. They say it is crucial to recognize the signs of heart trouble, which can be very tricky if you're a woman.
You have to listen to your body, listen to symptoms, but it's risk factors. So if you have a history of high blood pressure, if you are a smoker, if you are a diabetic, if you have those other things that set you up for a heart attack, then we need to pay more attention and be more aggressive with recognizing those symptoms.
They can have the typical mid-sternal chest discomfort, but a lot of women may just have a little jaw pain or arm pain, back pain, and sometimes it could just be nausea or abdominal pain. Unfortunately, I've seen women who have no symptoms at all that end up having blocked blood vessels.
Heart health is so important, especially in our region, and it's so important that we have dedicated and began an entire program called All Things Heart. So every Thursday at 10 a.m., we're going to dive into a new and unique topic that is all heart related, from sleep disorders to epilepsy, dental work, transplants, life-saving surgeries. Our first topic, however, will be a deep dive into heart complications from COVID. This story is remarkable. Our first episode on February 17th, you're going to meet two women who were in tip-top shape. I mean, they're in the prime of their lives before they caught the virus. Now they're both suffering extreme heart trouble nearly 2 years after surviving COVID. They have such heart problems now. So we invite you to watch, bring your questions, and join us for our very first live episode of All Things Heart on February 17th, beginning at 10 a.m. You can watch right here on Facebook or on YouTube, wherever you join us. Tell your friends, bring your questions. We can't wait to connect with you all on All Things Heart.
Alexis, we're so excited. I know you've been working so incredibly hard behind the scenes to pull this fantastic show together. So we are waiting and we will be watching, and we're just really excited. So thanks for all your hard work on that. So that will be
My
February
pleasure.
7th. That'll be on February 17th. That's where she's going to take that deep dive into those heart-related problems due to COVID. But today we're going to talk about some other debilitating things that people are suffering. We've been talking about these folks. They're called COVID long haulers. For the majority of long haulers, they have to go see a doctor or a specialist to deal with that. From July until December of last year, the health system averaged about 150 post-COVID patients per month. So I do want to turn back to our guest today, Dr. Sale. I just kind of get us updated a little bit about what are some of the common long hauler symptoms that people have, and then anything new that you're seeing?
So just I tell you, the most common things continue to be what we saw early on, which, first and foremost, fatigue and an overwhelming sense of just tiredness and weakness and just not feeling right is probably the single most common symptom that we see, but it's coupled pretty closely with musculoskeletal complaints, so joint pains, muscle aches, and I mentioned weakness a minute ago. And then the third big component really comes down to pulmonary issues. It's shortness of breath. I just can't catch my breath like I used to, and I just feel like I'm running out of gas sooner than I used to. And so those are probably the big three that we're seeing in most of our patients.
I can't imagine that feeling of just not feeling right and not being able to really pinpoint what it is and not even knowing where to start, right?
Well, and that's what's so challenging for our patients, because they don't know where to start, because it's oftentimes not just one symptom, it's 2 or 3 or 4 symptoms. When you look at some of our information with the patients that we've seen, they're not coming in to see one specialist. They're coming in to see 2 or 3 or 4. More than 50% of the patients that we're seeing for this need more than one specialist just to try and figure out what's going on. So it's a very difficult problem.
And people are still coming and utilizing the long haul clinic.
Absolutely.
And how is that? How do people get in touch with you? I want to ask that because we do get a lot of questions about, a lot of our viewers have long haul symptoms or know someone who do.
So our main call center is the entry point. So it's 913-588-1227 is the main number, and that kind of helps you get into the process of getting in to see one of our specialists. It really starts, though, with your primary care physician. Okay. They're the quarterback for your care. They're the ones who really can, to use Chief's analogy, they're the ones who can really drive the direction and the outcomes for your treatment. I think once you've kind of exasperated or run down all those leads with your primary care physician, that's when it's time to begin looking for a specialist and begin to say, okay, what else needs to be done because I'm not getting better.
So we're talking about some kind of unusual symptoms that some people have come forward and saying that they have, like itchy scalp, hair loss. We talked about COVID toes at the beginning of the pandemic. Are we still seeing those? And do people call in and say, look, I've got this I had COVID and now I have something weird that's happening. Yeah. How do you make the connection?
Well, that is one of the challenges, I think, with any kind of a post-viral syndrome is it's tough sometimes to connect the direct effects of that viral infection that happened 6, 8, 9, 12 weeks ago to the current symptoms that you have now. And certainly we do see dermatologic manifestations, right? Whether it is the Aaron Rodgers COVID toes or something along those lines. But there are a lot of things, whether it's itchy scalp or hair loss, that are associated with other viral infections, not just COVID. Right. And so I think all of those things are not uncommon and unique to COVID, but they do exist in certainty. You heard about the cardiogenic impacts that are out there, and so we certainly see a lot of cardiac effects in patients. And so it really can impact multiple organs, whether it's your renal system, your heart and cardiology or cardiovascular system, your neurologic system. All of those are at risk because it's an inflammatory disease that really can attack any part of your body.
God, such a mystery, and I'm sure you're just learning so much. I mean, just a short 2 years of time, and these patients that come with all sorts of different stories to share about their post-COVID symptoms.
Yeah, the challenge is the data is really overwhelming. There's so much information, and it's hard sometimes to, as you mentioned earlier, to distinguish between what is actually COVID and not COVID related, and so we're still trying to sort through that. which means it's a pretty murky area right now to try and understand what the impacts are of COVID and how to treat long hauler syndrome, and is this really COVID or something else. It is really shedding some light, though, on the impact of viral illness in terms of how it can affect the multiple organs in our systems.
All right, so we did have some hope on the COVID prevention front yesterday for immunocompromised people in the form of a treatment that recently received emergency use authorization. We've given more than 100 shots of Evusheld to bone marrow, kidney, and liver transplant patients, as they are the most severely immunocompromised patients that we have here. Peggy Field is the first immunocompromised patient outside of the transplant population to get this shot in our vaccine clinic. She has rheumatoid arthritis. Normally, vaccines help your immune system produce antibodies, but this treatment creates antibodies for people like Peggy, and she has been so incredibly worried that she might catch COVID.
We got the first two and we got the booster, and I was like, I am good. I can go anywhere I want. And then I found out that they didn't work. So the doctor said that this shot was coming up, and I was super excited. I couldn't wait for it so that I can feel comfortable again going out.
Good news for her and so many folks. So Rick, so for people like Peggy and other people, we've administered 100 so far. Does this require special infrastructure? That's a lot of things. People say this about monoclonal antibodies. Why can't people just come and get them? And it's not just that easy. But tell us about what kind of special setup we'd have to have.
Right now, honestly, with these shots, they're a little bit easier. It's still something you want to administer in a healthcare facility because we just don't know how people are going to react because the medication is so new. But that's probably the biggest infrastructure for the shot, for the Evusheld shots in particular. Many of the monoclonal antibodies actually also require some sterile preparation, and so you have to have a facility that's where you can do that in a safe manner.
So let's talk about monoclonal antibodies. How are we doing with supplies? What can we tell people? We get this question daily from several people about how they get them.
Yep. So, there's 3 monoclonal antibody products that are out there in the FDA, but only one that's really working right now for the Omicron variant. So, and that product is newer. And like I've said other times on this show, Jess, when these drug companies are producing these new products, manufacturing is limited. The control of the supply is coming through the government, and so we only get what we get. It's allocated, and everybody's trying to do the best to get the medications where they're needed the most. But with this new antibody, it's leaving our stock as fast as we can get it in, and so until the manufacturing chain gets up and running and we have a steady supply. The good news is it's not sitting on the shelf. We're getting it to patients, but our demand is outpacing what we have.
Dr. Hawkinson, you had some comments.
Yeah, I think we should also clarify that these are 2 monoclonal antibodies, but one, just as Rick was referring to, is for treatment. If you get infected, you will be getting a treatment monoclonal antibody. That's sotrovimab, and unfortunately, I think there are 4 on the market, but 2 at least have had their EUAs removed right now because they don't work against Omicron. So really the only one to work is sotrovimab. The other that we have talked about, the Evusheld, is for pre-exposure prophylaxis. So this is prior to getting infected or prior to knowing that you have exposure. This is mainly for people who are immune compromised, who may not make an adequate immune response to the vaccine or for another reason are unable to take the vaccine.
I want to go ahead and get to some community questions. I've got a few more I'm going to weave in there, but I want to ask this question from Brian. Where are the new COVID medication pills that can be given when diagnosed with COVID? Some people are reporting on the news that these medications are just being sent to New York and to certain places. So help clear that up. What are these pills? Where are they at?
Yeah, no problem. I'm happy to talk about that. It's the same story that I just was talking about with the new monoclonal antibodies. Those pills are available. They're not widely available, and I haven't checked this last few days, but you can look where they're available in Kansas, and they're distributed through the government. So they're coming from the federal government to the state governments, and in Kansas they've elected to go, I believe, right now just with Walmart's pharmacies. So you have to get a prescription, and then you have to find out from that individual pharmacy that you want to go to whether they have those products in the shelves or not. Broader availability will come about as the manufacturing increases, and we're being told that in the spring, like maybe in April, we'll be able to have those drugs on our shelves here at the health system.
And issues with supply, we talked about this last time you were on. This is something you deal with all the time. This is why this is your job, is to kind of figure out those situations, right?
And unfortunately, a large part of my job, yes.
Right, exactly.
Right.
So it's not just COVID. I mean, these supply issues come and you've got to figure out how to route them through and
That's right.
and how to
Yeah.
shift and pivot, as we have said. That's the word of the day.
Right.
Isaac wants to know, just curious if you would know this offhand, but what would the penalty be for a pharmacist who refuses to prescribe or fill a prescription for one of these drugs that that they've been forced to have to fill? Let's say it weighed on their conscience not to do it. Any word on that, or just any insight either of you could give us to that?
Well, so if if this movement came into actual being into law,
Right.
so then that's part of what it would is that it would shield the pharmacist from having to do something that they thought was wrong. And doesn't shield you from knowing that you did the wrong thing,
Exactly.
Right.
which is its own impact. But in current state, if a pharmacist makes the election to not dispense a prescription to a patient because they feel like it's unsafe or ineffective, there's not a penalty. That's their job. But
Exactly.
it sounds super controversial on like conflict oriented, but it isn't. It's just like, if Keith or Dr. Sales sends me a script and I get it and I think this is wrong, you know what I'm going to do? I'm going to say, hey, patient, I think I got some questions about this. Let me call your doctor and talk to him or her. And then we're going to have a conversation and we'll clear it up and then we'll figure out what to do and move it along. That's what would happen in today's day. So.
Yeah, as you said, it's a team effort, right?
Yeah.
And so there are instances where they may have information that I don't have. Maybe it's a patient allergy to amoxicillin. I don't have it. They didn't mention it to me when we talked to them about their allergies. They forgot it, omitted it, whatever. It goes to him. He captures it and says, hey, by the way, did you know this person has an allergy to penicillins? Oh, well, let's change that medication. So it's that checks and balances
Yeah.
that's super important to making our patients safe.
And I don't think patients realize that that's happening.
No, and from a liability or risk perspective, there's actually more risk or liability on the pharmacist if they dispense something and they had concerns or they didn't really look at whether it was safe or effective, and then something happens to the patient. So, because that's their job.
Yep.
That's what we do.
Another question is, do you think Paxlovid will be over the counter one day?
That is a really hard, murky crystal ball to look into, given that it's barely on the market right now.
Yeah.
Probably not, would be my guess, though. I'm just saying that because of that particular product has a number of side effects, and there aren't any oral antibiotics of any kind that I know of that are over the counter right now.
Mm-hmm.
And there's a lot of good reasons for that. But
Yep.
All right, question from Joe is, what is the most common long hauler symptom that you hear, the most common? And then what's one of the most rare that you've...
The most common that we're seeing in our organization is musculoskeletal. Our rehab medicine team by far is the busiest group, and they are the ones who are doing and dealing with the weakness and the neurologic sequelae of COVID. So I think that's probably the number one. Close second is pulmonary, so persistent shortness of breath, persistent cough. The rarest, that's a tougher one because we don't necessarily track the rare ones because there's a ton of one-offs.
Right.
In my own clinic, certainly, if you saw that board that was up earlier, the bottom end of that is otolaryngology, and ENT is loss of taste and smell. And so of the things we see that are the least common, loss of taste and smell persisting is probably on that, there you go,
Yeah.
probably on that list of things that are least common, and certainly not uncommon. But if you look at all the things that we see from a COVID perspective, that certainly does stay on the board, but not as much as things like shortness of breath or weakness or fatigue.
A lot of those scary symptoms that would not be fun to
Right.
be experiencing long term. Okay, handle Carpe Diem is your hospital administrating monoclonal antibody injections for immunocompromised patients versus the infusions. Who wants that one? And help us know what the difference is between the injection and the infusion.
yeah.
You can start.
Yeah.
All right, Rick, you start.
Evusheld is the injection.
Okay,
So, and Dr. Hodgson covered this already. So that's the protective, like prevent.
And
you
that's
from
what we
getting-
saw
Yep,
from
that's
our
what
patient.
what you saw, and the other products that are monoclonal antibodies are infusions.
Yeah.
So
I think there was data to support treatment monoclonal antibodies such as, but I don't know if it was sotrovimab or if it was the Eli Lilly product or the Regeneron product that had data supporting subcutaneous injections. But again, we aren't using those right now. Currently, for the treatment monoclonal antibody, we are only doing the infusion. And just as Rick said, for Evusheld, it's infusion as well.
Injection.
Injection, sorry.
All right, I'm going to give the last question from Kristen. Dr. Sale, have there been any studies done on people who've been vaccinated and boosted, or maybe even just vaccinated, who have developed long hauler symptoms?
It's a great question. I would tell you there are a couple things you can do to prevent long hauler syndrome. One is don't get COVID, right? That's the easy answer. Two is get vaccinated because there is good data to suggest that those folks who are vaccinated and then get COVID are less likely to get long hauler syndrome. Three, if you've had COVID and then get vaccinated, there's good data to show that actually it has some protective benefits and symptom mitigating effects if you get vaccinated after having COVID and have symptoms of long hauler. So those are the three big aspects that are out there around COVID and long hauler syndrome and vaccination. So I think the bottom line for me is if you want to minimize your risk of long hauler syndrome and or mitigate those symptoms if you have it, vaccination still is that answer.
So glad you guys were with me today. Go Red Friday for women.
Yeah.
Go Friday, Red. Okay, good. Thanks for doing that. Let's get to our final thoughts. Rick, I'm just going to let you get us started. Go for it.
Sure. No, the supply and demand of these drugs, the pills and the monoclonal antibodies, all those kinds of things. So if people have questions about this, they're so new. We're just going to have to wait. I mean, that's kind of unfortunate. And I know we're probably kind of a broken record. Keith just said this. I think Stites says it every day. Don't look for the treatment, look for the prevention, right? So vaccination is really the way to go. And we didn't talk about Novavax today, but I'm excited that there's more vaccine products coming out in the market because I know some people had concerns about the safety and efficacy of the mRNA vaccines. Novavax is a new one that we're looking for pretty soon to come out that's different. So maybe that'll be more comfortable for
I know,
some
another
folks.
crystal ball moment.
Yep.
How you say soon, how soon is soon?
You know, that's a question for the FDA, Jess.
Okay, I'll get right on it.
All right.
Dr. Sale, final thoughts on this Friday?
I'd say two things. One, Dr. Stites mentioned sometimes the difficult folks that we see in our organization. I actually want to go the other direction and say thank you to all of those folks out there who have taken their own time, their own money, their own resources, and brought in thank you trays of snacks or cookies or goodies to our healthcare teams because they really appreciate that. It really does brighten their day and makes a big difference and reminds them why they're doing this 2.5 years into a pandemic and in taking sometimes the abuse that they get at the hands of either their patients or their families or other folks in the community. So thank you very much for that. The second thing, as Rick mentioned, is there are ways to prevent long hauler syndrome, and we do have access and treatment options for those folks who are suffering from COVID long hauler syndrome. But the number one way to not have to go into those areas is to prevent it, and so we encourage folks to get their vaccine.
Dr. Hawkinson, final thoughts from you?
Yeah, I mean, I think Dr. Stites brought up some great points earlier. I think this continues to be a pandemic of multiple populations, most notably those populations that are vaccinated and boosted versus those that are not. We know that it continues to hold true that the vast majority of hospitalizations continue to be in those people that are not up to date with vaccination. So it continues to be extremely important now. As we know that new variants come in, new variants arise, we are currently in the downtrend of cases and hospitalizations, and that's great. If you haven't gotten vaccinated, protect yourself for the future. Please go get vaccinated. If you need to get up to date with your booster, please go do that.
Dr. Hawkinson, thanks so much. We'll see you on Monday. And Dr. Sale said it. Before we go, we want to say another thank you to all the doctors and nurses and other staff members helping to treat everyone during the surge. And to those watching, we appreciate you showing up and remembering us. So sometimes healthcare workers can feel like they are kind of on this island alone when they come to work here during a pandemic. They haven't been able to take breaks that they need. And this has been going on for 2 very long years. And that's one reason why the Rejuvenation Station was launched. Pushed around by volunteers here at the hospital, the station gives workers a break. It's filled with all sorts of good stuff, candy bars and chips and water and hand lotion and stress balls, all the stuff we all love. The rolling station was started by the health system, and then most recently, the Church of the Resurrection in Lenexa made a large donation to help keep it full for a while. So Tammy Peterman is the Executive Vice President, Chief Operating Officer, and Chief Nursing Officer for the health system.
It's very important for all of us within our organization as well as people outside the organization to recognize all that our staff are doing, our physicians and nurses and therapists and support team. They're all working really so very hard, and they're never thinking of themselves, they're always thinking of others.
Yeah, those treats and candy bars go a long way. Thank you all for being with us today. Don't forget, you can catch our shows anytime by logging on to our Facebook page and our YouTube channel coming up on Monday.
I just hope that we can have everyone get the care that they need. It is kind of hard these days when the volume does get so rigorous, but it is kind of disheartening when you see up to 50 people in the waiting room.
The emergency room and waiting rooms are packed, overworked hospital workers, tired, but still doing all they can to make sure everyone who needs care gets it. We're going to take a look inside a typical day inside the ER and share the message those staff members have for you if you do need emergency care. So everyone, please have a safe, fantastic weekend. We'll see you back here Monday at 8.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.